Yeah, you can start now.
Good evening, everyone. So, welcome to today's case presentations of Eye to Eye online series. Today, we have with us uh, three another three most important cases which are kept in exam. One is glaucoma, that is angle closure glaucoma. We have already finished open angle glaucoma on day one. So, this is an angle closure glaucoma. And we have post penetrating keratoplasty, a graft rejection case, which is usually kept as a spotter as well as for the case discussion. And then in the retina part, we are having the PDR with VH case. And this is most common kept retina case. So today's all three cases are like 100% case for the case presentations in your examination. And we have with us Dr. Krishna Prasad sir, who is HOD, Department of Pediatric Ophthalmology, Oculoplasty, as well as and glaucoma in MM Joshi Eye Institute, Hubli. And we have Dr. Aniket, who is the consultant Department of Cornea and Refractive Surgery in the MM Joshi Eye Institute. And we have Dr. Giriraj, who is a consultant of Retina in MM Joshi Eye Institute. So with them, we would be proceeding with our cases, and the case presentations would be done by Dr. Shriya from HV Desai Medical College, Dr. Mansi, and and Dr. Shanmugapriya. So first, we will be presenting the case of PACG, angle closure glaucoma, and that would be initiated by Dr. Shriya. Dr. Shriya, over to you.
Thank you, ma'am, for the opportunity. I will be presenting my case. A 42-year-old female patient came to the OPD for a routine checkup. On probing, the patient gives history of intermittent redness in the eye, right eye, associated with headache, which relieves spontaneously. There is no history of any discharge. There is no history of any allergic conditions in the past. There is no history of colored halos or glare. There is no history of any frequent change of presbyopic glasses. There is no history of using glasses for distance vision in the past. And there is no history of ocular trauma or any use of chronic medications. On past history, there is no history of hypertension, diabetes, bronchial asthma, or any cardiovascular diseases in the patient. The personal history, bowel,
Okay,
bladder.
Shreya, just a minute.
Yes,
Okay,
sir.
why are you asking history of diabetes and hypertension here?
Sir, as this is a 42-year-old female patient, and there is redness and headache in the patient, it can be due to diabetes that there is frequent, as in the patient can have a frequent change of glasses, or there's a refractive error change where the patient might experience blurring of vision, because of which the patient can come for a
See,
routine
with the
checkup.
chief complaints, okay,
Yes, sir.
see, normally this is where this is not basically your evaluation session. I'm not trying to evaluate you. I'm only trying to help you.
Yes.
In the real exam, they will not help you. They will evaluate you. Okay, so this is the opportunity for all of you to understand that whenever we present a case, you should be very slippery. You don't create opportunities for people to stop you. See, you are starting, even though Dr. DP alluded that we are presenting a case of PACG, PDR, it doesn't go that way. Some examiners, do not want to be kind of brand a case as a particular diagnosis because there are many other things. The same patient of yours may have a pterygium. Okay. So it may be a case of pterygium also. The
Yes.
patient may have some kind of a corneal opacity, may have some AMD changes. It can have some other retina finding. So basically, don't, I mean, create a custom make, like, some kind of a tailor make made histories. Okay. Normally, we have given you this. This is how you normally present. But at the same time, try to think when you take a case in the actual exam. Are you obsessed with the diagnosis or are you doing a reverse engineering? Like, this case is this. So everything starting from the chief complaints to your history of presenting illness to past history, everything you are tailor making it to only to fit that diagnosis.
Yes, sir.
If the patient says, I can't see, it need not be glaucoma. It can be
Yes.
cataract, it can be refractive error, it can be anything.
Yes.
Okay, so your history of explaining those chief complaints should encompass these things also. So when I asked you hypertension, diabetes, you should have some ready-made answer. See, if patient is 42 years and patient can be hypertensive diabetic. It's
Right.
important because it's going to affect the clinical course of any eye condition which may be having this chief complaint, like even cataract or whatever. Okay, the patient is a diabetic. And I would like to know it can cause there can be changes of diabetes in the retina, right? If the
Yes.
patient is hypertensive, let us say this turns out to be glaucoma.
Hmm.
Patients of diabetes have a higher propensity to develop POAG, and
Yes.
even the changes on the optic nerve head, okay, because of high pressure are much more detrimental in the case of a hemodynamic crisis like hypertension and diabetes.
Hmm.
And also, if the patient is on oral beta blockers,
Hmm.
the IOP can be slightly
Yes.
lowered because of the systemic beta blockade.
Hypertrophy.
So that can be a confounding factor. So you should try to keep these things ready whenever you are asked in the exam. Okay, so
Yes.
go ahead.
Um, so past history, there is no history of hypertension, diabetes, asthma, or any cardiovascular diseases. Personal history, the bowel bladder appetite was unaltered, and there is no history of any smoking or other addictions. On family history, there was no family history of any ocular diseases.
At the same time,
Yes, sir.
even this history is probably is admissible. You can say the patient had this. So you are basically telling a story, right? Patient had this problem. Then she went to the local doctor. She was told that she has glaucoma. If
Okay.
that is the history, okay, it is not wrong to say that word. So she was
Hmm.
asked to actually put on medications. She
Yes,
was
sir.
put on medication. Okay, if she knows the name, you can tell the name, or you can say she has some medication twice a day, which was supposed to be for reducing the intraocular pressure. She said, okay. So once you say that, then you may probably talk more about glaucoma. You can say there's no family history of glaucoma
Yes.
because now that you are with that history, treatment history, you know that you may be dealing with a case of glaucoma. Okay, so you would say patient underwent a laser treatment, which was
Hmm.
supposed to be for a glaucoma laser treatment, maybe a PI, or maybe patient have undergone a surgery for
Hmm.
glaucoma filtration surgery. So if that they are in the history,
Yes.
okay, you can be more pointed towards a glaucoma diagnosis. Okay, so all these, I'm just saying that this is a one case, but this can come in myriad presentations. You might have 10 different presentations of a PACG or a POAG,
Yes.
sometimes post trap status, maybe post PI status, okay, maybe post AGV status, maybe a post combined cataract glaucoma. So there are many things that can happen. Okay, so you should be very flexible enough to understand. I mean, see that you don't get caught in this the history itself. Okay,
Yes.
and don't waste too much time on the history which is not really contributory to the diagnosis. Okay, like addictions and
Addiction.
all that. So try to quickly, you can say no. Some examiners will appreciate if you say not contributory and go ahead. Okay, obviously it is not contributory, right? So
Yes, sir.
there's nothing you can ask 100 different things. But if it is not contributing to any of your history taking or making a diagnosis, you can say not contributory and complete. So now come to the actual ocular examination proper.
Yes, sir. Um, Visual acuity, the best corrected visual acuity was 6.6 in both eyes and N6 for near vision. On anterior segment examination, the
Oh,
lid and
stop. Again,
yes,
see, you're giving me too many opportunities to actually teach. Vision, this
yes,
is
sir.
something that you can't make a mistake. I told in the earlier class also, please rehearse, please get through this simulation exercise. You are going to present this exam case only once in your lifetime. That is in your exams for a most important outcome. Okay, you're going to pass the exam. So don't take any chances. When you say vision, as an ophthalmologist, you're presenting one story to another ophthalmologist. I would like to know many things in this. You said
Yes.
BCVA 66 and went ahead.
With
It says nothing.
refractive
What is
correction,
most important is,
the
see,
refractive
some
correction.
people would want unaided vision.
Yes, sir.
She may be 6 N6 with +6 for distance, or she may be 6 N6 with -3 for distance. She's a myope, she's a high hyperope, she may be a high myope, she may be -12 and still 6. Does it make a difference?
Yes, sir.
Yes, it makes a lot of difference. So the refractive status of the eye makes a big difference in any diagnosis. Not just this, even retina for that matter. Retinal detachment, if you're presenting a case of retinal detachment, you
Yes, sir.
can't say 6 and 6 and go ahead. You have to tell me the refractive status, a high myope, It is a predisposing factor for retinal detachment. Do you get that point?
Yes, sir.
So any situation, so basically the least, or the most pertinent thing that you tell in the vision is what is the BCVA you can tell. I have no problem.
The
But
CVA
you
books.
need to tell me the acceptance.
Yes.
Patients accept. Our patient is plano 6.6 in the right eye and N6 with plus 1.5. Patient is okay 6.6 with minus zero point 0.5 diopter sphere, and she again accepts 1.5 for near plus
Yes, sir.
1.5. So this is what then I come to know, okay, that the patient is not having a very high significant refractive error. Okay, some examiners would want you to give an unaided vision, pinhole vision, BCVA. Okay, BCVA is always with spectacles, not with pinhole.
Yes, sir.
Okay, there will be some questions on that. Why pinhole vision is not always as good as the BCVA? You should know the reasons.
So
Okay,
because yes.
tell me the answer.
So because pinhole vision is just trying to rule out if it is a error due to refractive error
So,
alone,
for
while
example,
rule
in which situation pinhole vision is 6.12, but the patient improves to 6.6 with glasses?
so if there's any posterior subcapsular cataract, or if there is uh, suppose if the patient has a age-related macular degeneration, which is only involving the
And they will not be
fovea,
6.6, no.
it with as in the pinhole is restricted to only the central foveal
See,
fixation.
very high refractive errors,
Yes.
very high cylinders. The pinhole vision will be less than the BCV. Okay. Then the pinhole vision can drop drastically in case of media opacities in the center. If you have a central corneal opacity, if you have a central dense cataract, then the pinhole vision can drop drastically.
Yes.
Okay. That is something that you should know. Okay. So go ahead with your examination. So what is the refractive status of this patient?
Sir, if I had to go along the case that is given, it
No,
would
no,
be
no. See, I told you, please make up your own case. We
yes,
are
sir.
just given a thing. If you are
Yes.
presenting, you should be knowing, you would have probably said patient has hyperopia
Yes, sir.
or patient be emmetropia. You should commit to something and go ahead with it.
Sir,
Don't
hyperopia.
leave the gaps.
Yes, sir.
This
Six
whole
six.
format is patchy intentionally. Okay?
Yes, sir.
Okay, go ahead.
The visual unaided visual acuity is
No, I
6.5
don't want unaided. I just
into
wanted the acceptance.
acceptance of plus 1.25 with no cylinder for distance vision going till 6.6 in the right eye, with the plus 1.5 near eye going to N6 in the right eye, with left eye plus 1.25 diopter sphere going to
Okay, you can
6.6
say
in
plus 1.25 diopter sphere both eyes 6.6
yes
and add of plus 1.5 going
1.5.
to N6. Go ahead.
Yes.
Next.
Anterior segment examination, the lids and adnexa were normal. Conjunctiva was normal. Cornea was clear and lustrous in both the eyes. On anterior chamber examination, the
See, again,
von
a small
Erichs,
correction. This
yes,
is
sir.
for everyone who is watching this. See, the examiner may still pick at this. Some
Yes,
people are obsessed with, okay, the head posture, okay, the facial symmetry, ocular posture, okay, at the same time, periocular skin, eyebrows, lids. So you try to create one quick format. Don't waste time telling slowly one by one. Quickly tell. Okay, head posture, this is everything's normal. Okay, lid posture, ocular skin. Because basically, we can't assume, no, there may be a problem in the lid. Patient may have a wart. Patient may have a varicose lesion on the lid. Patient may have some madarosis. Patient may have some ocular skin may have some changes. So you're not just presenting only glaucoma for me. I'm telling everything about the case. So patient may have some kind of a facial asymmetry.
yes,
Patient may have a ptosis, patient may have a proptosis. So there may be a facial, ocular asymmetry also. So all these things make a format, mug it up, and be very quick in saying that in a major case. Okay,
yes, sir.
some examiners may not be really worried about this, but I'm trying to say you should be ready for all kinds of examinations, there's a cultural thing. Many examiners come from different backgrounds, so they expect everything to be like this. Some people are okay with your diagnosis. Okay, so don't give chance for all this. Try to be, try to cover 100% of all the requirements that is expected from you in an exam. Okay, so go ahead. We don't have
So
to correct
should
that.
I?
Just I'm trying to as a kind of a input for
Yes,
all
sir.
of the people who are watching.
Yes,
Next.
sir. The cornea is clear and lustrous in both the eyes. On anterior chamber examination, the von Herix grading in the right eye was 1, whereas in the left eye it was VH1 as well. The iris was
Okay,
normal in.
stop. See,
Yes,
you are again missing the point. You are just obsessed with the diagnosis. Anterior chamber, you have to give me a qualitative assessment.
yes, sir.
Is it normal depth? Is it deep? Is it shallow? It
Yes, sir.
is nothing to do with Van Herix.
Okay.
Van Herix is only a peripheral anterior chamber depth.
Yes,
Okay,
sir.
it is a semi-quantitative thing and it does not say anything. It can't say just looking at Van Herix, you can't guess the gonioscopy finding.
Yes,
Okay, but the central AC depth may not always match the peripheral AC depth. It's not always that a Van Herix, if it is shallow, peripheral
yes,
AC depth, the central AC depth has to be shallow.
yes,
Central AC depth, okay, by putting a pen torch on from one side or by looking in the slit lamp, you have to comment only three things: normal depth, deep AC, shallow AC.
yes,
Even deep AC is abnormal.
yes, sir.
Can you give me two situations where AC is deep?
Sir, in a high myopic patient, or if there's any subluxated cataract patient.
Exactly. So it can be anterior megalophthalmos, it can be
Mm,
keratoglobus, it can be megalocornea, it
mm.
can be a high myopia, it can be a subluxated lens. Why not in pseudophakia?
So in pseudophakia, we're placing it in the bag where it is in.
Pseudophakia AC is deeper
Then no,
because
yes,
the normal 4 millimeter lens is replaced by 1 millimeter
one.
pseudophakia. So AC is deep in pseudophakia and also in aphakia. Okay, so they would expect you to tell aphakia pseudophakia first.
Yes,
Right? Okay.
yes,
So I'm just giving you how you can be kind of caught during your examination. No, these are the things. They may not talk anything about your glaucoma.
yes, sir.
You're ready with your diagnosis and management, but you may be caught in AC depth only.
Yes,
Okay. So
yes,
please mention AC depth, then go to Van Herix.
yes,
Right?
yes.
Ah,
So AC is shallow in both the eyes, and on peripheral von Herix is one in both eyes.
hmm.
Iris is normal in color and pattern in the right eye, whereas there is iris atrophy in the left eye. The pupil is
No, you have
mid-dilated
to be
and.
more descriptive about iris atrophy. You have to be more descriptive because a very severe iris atrophy is different. Okay, very minimal iris atrophy is different. Iris whorling is different. There's a
Yes, sir.
change in the colorate that is called iris whorling.
Whirling. Yes,
Okay,
sir.
there can be a small area of atrophic patch somewhere.
Yes, sir.
Okay, so you have to tell the even the quadrant and the extent, the severity of iris atrophy also. Okay, anyway,
Okay.
no problem. I'm just telling you, you don't have to change now, but go ahead. And normally, most of them will be associated with pigment dispersion. So
Yes,
if
sir.
at all you have an iris atrophy, you can also probably look for pigment at the back of the cornea.
Got it.
Okay, next.
Pupil is mid-dilated and sluggishly reactive in both the eyes. Uh, Lens status is nuclear sclerosis
Pupil
grade
is
1.
like, come again.
Pupil is
You are
mid-dilated.
you are telling tandem right and left together.
Yes, sir. I was
Okay, there are
doing
two
that.
ways of doing it.
Yes, sir.
You can present the one eye first, then the second eye. Okay.
Okay.
For example, one eye is almost normal with less minimal findings, whereas the other eye is abnormal.
Hmm.
Then you can say, see, by convention, we always talk about right eye.
Yes, sir.
Okay, there's no reason. It's a convention. It has no logic. Right eye, left eye. So if let's say the right eye is almost normal, left eye has some finding. For example, let's say retinal detachment in the left eye. You can tell the examiner, sir, I would like to present the left eye first.
Okay.
That is
Yes,
with a
sir.
prior permission, you can break the convention.
Yes.
Okay. Then you go ahead with completely everything, all related to. If you are jumping from right to left, you are confusing the examiner also. And you are also
Yes.
getting confused.
Okay.
and you are not spending enough time at the eye, which is more important.
Yes,
Then
sir.
after finishing that, now I want to talk about right eye. If there is
Yes.
everything is normal, let us say, except the things that you are need to see, okay, you can say is within normal limits. The adnexa, the lids, oculus conjunctiva, cornea, as well as anterior chamber, everything is within normal limits. You can
Yes,
just
sir.
finish all that. Pupils
Yes,
are
sir.
normal, or they can say, for example, other eye has got a total RD.
Yes,
So
sir.
you will have a direct refraction will be normal. The consensual will be sluggish
Yes, sir.
because the other eye is having some retinal condition or
Retinal.
some optic nerve condition.
Yes,
So you can say that just to score a point.
yes,
Okay, then the media is clear and the retina is normal, and I would then you would say I'm talking about retinal detachment case.
the
Sir,
left eye
here
has.
I have seen the central retina looks normal. Okay. See, you may always talk about CD ratio, you may talk about this size and everything, but that is not important. A person to whom you are presenting a retinal detachment in the left eye may not be interested to know CD ratio, disc shape, size in the left eye, right eye. You can say the central retina looks normal. I would like to do a peripheral retinal examination for any retinal breaks. You get the point? I
Yes,
am
sir.
trying to kind of create a
Format.
situation where you are trying to know, you are trying to tell the examiner the other eye findings are important. This is the most important finding, which I have not done.
Hmm.
Similarly, here, okay, you can present the eye which is abnormal first. The
Yes, sir.
other way is to go from right to left. Every case, you can start from right to left.
Okay, sir.
Go right eye, left eye, right eye, left eye. So that is also fine.
Okay,
But
sir.
I would rather want you to tell one eye first, preferably the abnormal eye.
Okay, sir.
Okay,
Sir, I'll
go
go
ahead.
ahead with only the right eye for now. The right eye, iris
No, you're
was.
fine. You can we can do the right to left. You can shift and keep telling both, no problem.
Yes, sir.
Whatever you're doing, continue the same.
Okay, sir. Lens status in both eyes had nucleus sclerosis grade 1. Left eye, there was glaucoma flecking present on the anterior lens capsule. On measurement of the intraocular pressure, which was taken by Goldman's applanation tonometry at 10 a.m., the pressures were 36 millimeters of mercury in the right eye and 30 millimeters of mercury in the left eye. And they were corrected according to the central corneal thickness, which was 525 in the right eye and 520 in the left eye. On going ahead with the gonioscopy, the angles were closed in all quadrants in both the eyes. Uh, the fundus examination in the right eye first. The media was clear. The cup size was normal. The cup to disc ratio was 0.7. There was a bipolar superior and inferior notching. So may I share the screen for the fundus evaluation?
No, you first tell, then share the skin. Let's see.
Uh, posterior pole examination showed presence of the foveal reflex, and background retina was within normal limits. In the left eye, the media was clear, the disc was normal in size, and the cup to disc ratio was 0.8 with a bipolar notch. Uh, there was also a bearing of vessel seen inferiorly. And the posterior pole, the foveal reflex was present, and the background retina was within normal limits.
Okay, stop. I think this is the most pertinent part, and you have messed it up a bit. See, this is a very important part of the examination because you are talking about a glaucoma case here. Okay, the disc is everything. So tell the media, is the media clarity okay? Then, but first you talk about the disc shape, vertically
Yes,
oval or
vertical.
whatever. Then the disc size. You have to tell how did you measure the disc size.
Yes, sir.
Okay, you should be ready with that answer.
Yes, sir.
Normally, the normal disc size is 1.3 to 1.8. Less than 1.3 is a small disc, more than 1.8 is a big disc.
Mm.
Okay, normally we take it as 2. If something is more than 2, so you can put that 2 millimeter of the Welschelen, or you can even use on the slit lamp. You can use a
Multiplied by.
7080 and put that 1, 2, 3 millimeter circular next to the disc. Comparing that, you can say it's a large disc or a normal size disc.
Yes, sir.
Okay. So You can say it is a normal size disc, but you should be ready to answer how did you
Okay.
measure that?
Yes, sir.
Okay, it's a semi-quantitative thing and a
Yes.
gross estimation. You are only trying to say it's a small disk, normal disk, or a big disk. And you should not also know the significance of that. A large disk will have a large CD ratio.
Yes, sir.
So it may be sometimes mistaken for a glucomatous disk. Okay. Whereas a small disk harbors glaucoma more because the NECD ratio is actually significant.
Yes, sir.
Okay. A zero point 0.8 CD ratio in a very large disk may be
Yes.
less significant than a zero point 0.6 CD ratio. And once you talk about shape and size, talk about CD ratio, always tell horizontal and vertical.
Yes, sir.
It is a must. In fact, all studies take vertical CD ratio. Most importantly, you should always take horizontal, and you can share the screen.
Yes,
So
sir.
horizontal and vertical CD ratio is compulsory, non-negotiable.
Yes.
Then you talk about neuroretinal rim. Okay, that is the order. You talk about neuroretinal rim. Is it fine? Is it okay? Okay, isn't rule violated or isn't rule is actually taken care?
Sorry, sir.
You put this fundus photograph.
Yes, sir.
Okay, you can make it full screen.
Yes.
Okay, so then you talk about the CD. Here you can see in the left eye. Let's I'm talking about the left eye. Okay, it's a
Yes, sir.
vertically oval disc. This vertical CD ratio is almost 0.8, where the horizontal CD ratio may be around 0.6.
Yes,
So
sir.
here you can see there is a erosion of neuroretinal rim both superiorly and inferiorly.
Yes, sir.
Okay, with a deflection of vessels.
Yes, sir.
Okay, so it's almost zero point 0.9 vertically, whereas horizontally it is. So I get a picture that what is the disc. I mean, at the same time you have to talk about the nasal neuroretinal rim is quite okay, healthy,
Yes.
and temporally it's a sloping
Sloping
temporal,
edge.
okay, part. It's a sloping disc.
Yes.
Okay, so here it is not a normal disc. There is a bipolar notching or a bipolar erosion of the neuroretinal rim. So
Yes.
which means that they will ask you what will be the perimetry findings in this patient.
Yes, sir.
What will
We
be the
can
perimetry finding?
expect we can
Huh?
expect biarcuate
Yes.
scotoma.
If there's an only inferior polar knot, there'll be a superior arcade
Superior.
scotoma.
Yes,
Here
sir.
there'll be a biarcade scotoma.
Yes,
Okay,
sir.
and since the nasal rim is pretty good,
Hmm.
so you will have a temporal field intact. That is
Yes.
why the temporal
Last one to
field
leave.
is last to go.
Yes.
Okay, because the nasal neuroretinal rim is the last to get damaged.
Yes.
Okay, they will also ask you why the superior and inferior poles get damaged first. It is because in the lamina
Maximum amount
crepuscular
of.
they are least supported.
Hmm.
Okay, the axons are least supported in the poles so that they get the brunt of the glaucoma first.
Raised. Hmm.
Okay, so this is so you need to first talk about I told you shape, size,
Yes, sir.
then the
Vertical
neuroretinal
and
rim, the worst of
horizontal.
CD ratio, vertical and horizontal, and then neuro it explain the neuroretinal rim. There can be
Yes.
a superotemporal excavation, bipolar notch, or there can be a concentric cupping. No, you may have
Cupping.
a very concentric as well as the localized damage.
Yes, sir.
Okay, that is what it is. Then you can talk about the vessel signs. Okay,
Yes.
bionetting sign, bearing of the circumlinear vessel. Okay, you can see laminar dot sign in
Yes,
an
sir. In the
advanced
right eye. Yes.
okay, in the right eye, you can actually have some laminar dot sign. See,
Yes.
these are not very important. They're not very diagnostic. They're all secondary findings following a concentric damaged neuroretinal rim. And the peripapillary area is very important. The disc
Hmm.
margin at the peripapillary area, you have got a alpha zone and beta zone. Here you
Yes.
have both actually,
Yes, sir.
left eye of both alpha and beta zone.
Yes, sir.
Then you can go and try to see the arterial attenuation. In advanced glaucomas, you have arterial attenuation. Then you also have neuroretinal rim, okay, RNFL defects, which is seen on
Red free
reticulate.
filter.
Okay,
Yes.
normally, in a very advanced glaucoma, you have a diffuse loss, you can't make it out. In a very early glaucoma, normally related to the localized neuroretinal rim damage, you have a normally a, okay certain clefts or defects in the. So
Red.
this is
Yes.
something that expect you to tell.
Yes, sir.
Okay, so let's say I think we already finished our time. You can come to the diagnosis now. Tell me what is the
Yes, sir.
diagnosis?
So this is a patient of a 42-year-old female presenting with intermittent episodes of headache and redness with shallow AC and closed angles. A case of close angle, subacute angle closure glaucoma in both eyes, along with presbyopic correction.
What is this diagnosis,
Presbyopia.
dear? Subacute angle closure glaucoma. Where did you get
Um,
this diagnosis?
um, I will- because of
What is the
intermittent
gonioscopy finding?
closed angles, sir.
Closed angle.
Uh,
So
chronic,
please, I mean, don't make such mistakes.
yes, sir.
Okay, see, I told you that's why your preparedness for the practical exam is very important. You should know exactly what you're talking. And this normally you have an ISGO classification of the ACG spectrum.
Yes,
Here
sir.
you are having a patient who has a high intraocular pressure.
Yes, sir.
You have closed angles, you have a shallow AC, and you have a disc damage in both eyes. And
Yes,
also perimetry shows certain changes
yes, sir.
corresponding to that. So all the dots are covered.
Yes,
It
sir.
is glaucoma
PACG.
because the pressure is high, angle is closed, there's a disc damage, perimetry is commensurating with it.
Yes, sir.
So it's a glaucoma. What kind of glaucoma? Angle is closed. So it is an angle closure glaucoma.
Yes,
What
sir.
kind of angle closure glaucoma? ACG has a spectrum.
Yes, sir.
Okay. The latest classification, the universal nomenclature now, which is applicable everywhere, is what is called as PACS,
Yes, sir.
primary angle closure suspect, where
Suspect.
you have occludable angle for two
Both
quadrants
the
or more,
entity. Yes.
with IOP being normal, disc fields normal.
Yes, sir.
Then you have angle
Closure.
PAC, where
Yes.
PAS develops, peripheral,
With.
I mean, anterior syndicate develops, IOP rises, disc is not damaged,
Yes.
which is less common to see in practice. Then it progresses to PACG, where you have angle closure with
With raised
syndicate,
IOP.
you
Yes.
have disc damage, you have field effect. So this is
Yes.
a case of PACG.
Yes, sir.
Why primary? Why not secondary? Because you're not finding other causes of
Causes of second
angle closure
closure.
glaucoma.
Yes,
By
sir.
exclusion of other causes, you're taking it as PACG. Now, I want you to give me at least three causes of secondary angle closure glaucoma.
Neovascular glaucoma can be a cause of secondary
Okay,
angle closure.
you have to say the angle closure stage of neovascular glaucoma,
Yes, sir. Angle
because
closure.
neovascular glaucoma also has an open angle stage.
Yes. So ICE syndrome can also be a cause of angle closure glaucoma,
Well,
or
I'll
it
still take it,
can,
eye syndrome, because the peripheral angle gets zipped off because of the abnormal endothelium. Fine.
uh,
You are
or
not
due to
talking
a
about the more
lens-induced
commoner ones,
angle,
no, day-to-day
sorry, sir,
practice, people who deal with cataract.
lens-induced, lens-induced angle closure
Lens-induced
glaucoma,
glaucoma. Which type of lens-induced glaucoma?
phacomorphic,
Phacomorphic glaucoma.
yes,
Then,
it can be a plateau iris or
no.
apposition,
Plateau iris is a primary condition again. It is not a secondary condition.
yes, um,
There is nothing wrong in the eye other than the plateau iris.
uh, so it can be,
You have a
uh,
subluxated lens coming forward and blocking it. Phacotopic glaucoma.
yes, sir,
Huh? You have a microspherophakia where lens and comes and blocks it.
pupillary, yes, sir,
Pupillary block, that's a secondary pupillary block.
yes, sir,
Have you heard of a vitreous blocking the pupil, causing a secondary angle closure and
yes,
angle
sir.
closure glaucoma?
Inflammatory,
You have a posterior syndicate blocking, causing an occlusio pupillae. So multiple causes, and you should know the priority, the sequence by which you answer.
yes,
Okay. So you need to get your theory right to prepare for your practical exam.
yes, sir.
Okay. So now tell me the management. I think we'll finish it off in next 2 minutes and give the case to the next person. What is the management strategy for this patient?
So firstly, I like to decide the target pressure. As in, first, we like to relieve the angle closure by planning for a laser peripheral iridotomy in this patient
Hmm.
in both the eyes. After that, once we start the topical medications and follow the patient up, after 2 weeks, when the inflammation will subside, we will look for the pressures again. And then we can set a target IOP for the patient and start the patient on medications, as in anti-glaucoma medications.
Okay, I'll still take
Yes.
it. For the left eye, looking at the disc, what is the target pressure that you want to keep?
So as it is a 0.8 cup to disc ratio, and we would
You
like to
also
keep
look at
it
the
in the
perimetry,
lower
not just
teens.
the
So
disc, you also look at the perimetry. 0.8 is not the
perimetry
issue.
also. Yes,
If you
sir.
have a large disc, high myope will have 0.8 with a normal field.
Yes.
So look at the fields.
Yes, sir.
Okay, disc and fields. Okay, so it
Yes.
is already a moderately damaged. Okay, so you have almost a moderate
Low to
field
mid,
defects. So what's the
low,
IOP you want to keep?
so low to mid teens uh, should be the target IOP.
Huh.
As the patient doesn't have any other risk factors or
So around 13 to 15 is something I want to keep. You can say that.
yes,
Not a problem.
yes,
See, there is no hard and fast rule. You can take any number. Even if you say 12 to 14, it is still acceptable.
yes, sir.
You would calculate low teens. So around 13
Yes,
to 15 or 12 to 15 is the range.
yes, sir.
Okay. So that is what. So always do a PI and treat the residual disease as OAG.
Yes, sir.
Okay, so you have to do a PI first. That's a very good answer. Okay, and then follow it up with basically try to see the agonioscopy again, see the angle has opened up, the outflow facility has improved. Then treat the residue. Pressures are still high, then you keep a target and go ahead with it.
Yes,
If the IOP doesn't get controlled, then you may have multiple options. You may think
yes.
of a trabeculectomy. Okay, can you do SLT, ALT in this?
So usually we do not advocate SLTLT in angle closure glaucoma.
Yeah,
It is
you're
for
not seeing the
pure.
trabecular issue. So even the MIGS also is not possible in
Yes,
ACG.
yes.
Okay. So you know any MIGS conditions, MIGS surgeries, minimally
Uh,
invasive glaucoma surgery, any name?
eye stent can be used, or a hydrojet can be implanted uh, in the
No,
angles.
tell me what is
Uh,
being used in India. No, eye stent is one, but rarely used because of the
some
cost.
KDB is done.
Yes, Kahook dual blade,
Kahook
use the
dual
full
blade.
form. Kahook dual blade
Kahook dual.
goniectomy.
Yes, sir.
Have you heard of BANG?
Bang surgery. Bent angle needed goniotomy can be done.
Have you heard of GAT?
Yes, sir.
GATT?
Yes, sir.
Okay, so that's good. Okay, very good, Shreya. I think you are quite brave and you have really presented it very well. But there are definitely gaps, and it is my
Yes, sir.
duty to actually correct you because you can't go away with a fake confidence that everything went well.
Mm.
It is my duty to be critical and tell you where you need to improvise. It is for rest of the people. You may be presenting, but you are representing a lot of postgraduates who are in the same situation. So my parting message is please go through a mental exercise, a simulation exercise. Think of a case. You see so many cases you have seen in last 3 years. So think of a case. Okay, what is the history? What are the findings? Okay, how to actually put it across, and don't mix up the things. And as I told you, follow these things. Don't assume the diagnosis and tailor make all your approach to the diagnosis. Try to be little general in the beginning. You may probably say something, but always be ready with the answer if they ask why. For
Yes,
things that you have asked, some history that you have told, you should know the connection. Why did you ask? Don't ask a history which is irrelevant. Okay. At the same time, don't try to keep on telling the history findings which are not of any relevance to the case. Like, please cut it out, say not contributory, and go ahead and come to the vision. And the
yes,
vision, don't please mess it up. Always tell the BCBA and
yes,
the
sir.
acceptance, at least that's the minimum requirement.
Yes,
And always tell the abnormal eye first, then come to the normal eye. Okay. In the normal eye, always try to score a brownie point by saying, okay, that you want to do some test because certain conditions are bilateral. Like I told you, as a peripheral retinal examination in case of a
in
other
the
eye
other
RT.
normal. Yes,
Okay, if one eye has keratoconus, obvious keratoconus, you would like to do topography of the normal looking eye.
yes, sir.
Patient may have good vision or just a myopia, but no complaints, but still you would like to do a
Form.
topography for a formoplastic keratoconus, something like that.
Yes,
So this is where you score and
yes,
always put all the points, most important points in your history and examination as a summary, then come to a differential diagnosis if possible and give a very crisp diagnosis. Don't have this conflict of interest. And you said subacute ACG is not a diagnosis that an examiner will take now.
Yes, sir.
Okay, it has to be a PACG,
PACs.
PACS, PAC. One eye may be PACG and the right eye may be PACS. Okay, so you have to treat each case differently
Yes.
and examine the findings as well as the management strategy has to be in place. Okay, okay, well done. All the best.
Thank you, sir.
Over to Dr. Deepthi.
Thank you, Dr. Shreya. Now we have our next case, be a post PK graft rejection case, and Dr. Mansi would be presenting that case, and that would be she would, and the examiner would be Dr. Aniket sir. So over to you, Dr. Mansi and Dr. Aniket. So there is one small doubt which one of the PG has messaged. If right eye is absolutely normal, and as it has been told to them that always right eye has to be presented first, irrespective of whatever it is. So can they say right eye totally normal in,
No, no, no,
and go with left eye
no, no, no.
PACG?
That is also okay. But what I'm saying is there is nothing sacrosanct. There is nothing, everything is a convention. If you are able to convince the examiner why you want to do left eye first, it's fine. I mean, that's a convention. It is not a rule. Okay, sir, I would like to first talk about the left eye, then come to the right eye. They will say, okay. Or if they really insist, I want right eye first, then they say right eye is okay. You can probably start telling the whole right eye thing first very quickly. Don't spend time on the normal eye much. See, the problem with all of you is you spend too much of time talking. Your talk time is limited. You need to impress the examiner within a short time. They have always paucity of time. So use it for your discussion. Don't bore the examiner with some irrelevant findings. That's why they'll ask you to skip. So instead of you skipping it, quickly tell. Make always a preparation. Whatever you think is not directly related, try to quickly tell and come to the examination.
Thank you, sir. Dr. Mansi,
Yes, ma'am.
yes, you can begin with your case presentation now.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. So, I will be presenting a case of Mr. Siddhappa Gangavati, 65-year-old male patient, farmer by occupation. Am I audible?
Yeah. Go
Yeah.
ahead.
A farmer by occupation and a resident of Gangavati. He presented to the OPD with chief complaints of diminution of vision in right eye, pain associated with pain, photophobia, redness, and watering since a week. So, history of presenting illness. The patient was apparently all asymptomatic 1 week back when he developed a diminution of vision in right eye, which was sudden in onset. It was associated with pain. Pain was sudden in onset, progressive in nature, progressively increasing in nature. It was dull, aching, non-radiating, and it did not get relieved or aggravated by any factors. It was associated with photophobia, redness, and watering. The patient had recently undergone.
You said so many things about pain.
Yes, sir.
Okay, in detail.
Yes, sir.
So how's it? I mean, is it relevant or it just adds to your diagnosis? You want to rule out something?
Sir, this
Pricking pain. What if it's a pricking pain?
um, sir, further, basically, dull, any pricking pain can suggest any surface problem. Dull aching usually can, suggest some deeper ache, something like that.
Okay, so basically, dull aching is something that occurs when your coats are involved.
Yes, sir.
Okay, coats, when I say it could be your cornea, it could be sclera or uvea for that matter.
UV,
When
yes,
they
sir.
are dull aching, there is anything that's pricking or such things or anything particular sharp, either
Yes,
it's
sir.
a foreign body or it's a suture in some cases that way. Okay,
Yes, sir.
right.
The patient underwent corneal transplant surgery 4 months back. He was on medications post surgery, which was stopped 1 week back. He started having severe pain and further diminution of vision in right eye since stoppage of medication. Going on to the past history. Um, Going on to the past history, patient suffered from trauma with a sugarcane stick
to the right eye 4 months back, following which he developed a corneal infection. He was started on medications for the same by local ophthalmologist. The infection progressed, and further the patient had to undergo a surgery. From the past records, we got to know that the patient had undergone a corneal transplant surgery for the same. Post surgery, he was started on medications. After 2 weeks, the patient another eye drop was added for the same, and the patient was symptomatically improving with these medications, and his vision was also improving. He stopped these medications around 1 week back, and this was followed by an episode of pain, blurring, and which was progressive in nature. Going on to the drug history, the patient was started on eye drop natamycin 5%, eye drop voriconazole, eye drop homide, lubricants, and tablet ketoconazole for the corneal infection. Later on, he after so this was post surgery that he was started on these medications. On the 2 week follow up, he eye drop prednisolone was added, and the patient was symptomatically improving. He stopped all these medications 1 week back, and presented with all these complaints. Going on to the personal history.
Okay, we'll just come back.
Yes,
We'll
sir.
just come back to that. One is you said in the past history that the patient had a penetrating keratoplasty.
Yes, sir. Corneal transplant.
Yeah, basically try to involve common words.
Yes, sir.
One. Second thing is some examiners may not like when you say that according to old reports.
Okay, sir.
So you need not be more specific.
Okay.
You could always say that probably patient underwent a surgery for,
Surgery.
yeah, he had a sugarcane injury, following which he had pain, redness, watering. How will patient say in a history that I had keratitis?
He can tell that there was some infection
Yeah,
which
they say
had
yes,
hit.
exactly. Whenever we talk with the patient, also we say there is some kind of infection or kind of thing in their cornea. So
Yes, sir.
those words are to be included more.
More. Yes, sir.
Okay.
So it was history, so I didn't want to be very specific like keratoplasty, so I just wrote corneal transplant, something like that.
Yeah, fine, good enough. If I'm an examiner, I don't mind. But
Yes.
still, some may not like that to use technical terms when you're presenting
Yes, sir.
history.
Yes, sir.
Okay. And second point I want to add is whenever there's a keratoplasty case, there will be 50% of the examiners who would want your keratoplasty history to be included in your presenting complaints.
Okay.
Okay. And there will be few people who would want it to be in
Past
past.
history.
Okay. So that is something which it's quite tough to know, but anything that is acute or subacute, say within 1 month or 2 months, you can always include it in your present history.
Present
Anything
history.
that goes beyond that, try to include that in past
Past.
history.
Okay, sir.
Okay. And then, of course, your treatment history.
Yes, sir.
Like you presented, what was he on before, what was he done before, after surgery, and this, what all drugs he was changed to. So
Yes.
now at this point, I ask you, what is your differential diagnosis?
So looking at the history, this looks like there was a corneal ulcer which he underwent a corneal transplant or something. So my first differential would be infection, a graft infection.
Right.
Then secondly, I would go for graft rejection since he stopped all those medications and then came with diminution of vision with pain. So I would think of that. In fact, I can also think of endophthalmitis as my third differential. Uh, uh,
Pain,
Pain,
photophobia,
photophobia. Also, sir, there can be any surface problem like filamentary keratitis or something. Then recurrent HSV keratitis is also seen in.
anything before that, all those things. If I say the top three diagnoses, pain, redness, photophobia, diminution of vision, that
Uveitis.
Uveitis is again, that's part of your rejection plan. Okay, then you have
Okay.
repeat infection, rejection,
Rejection.
dash, then endophthalmitis. Endophthalmitis, only pure endophthalmitis as such in a post PK case will not have so much of what do you call intersegment reactions like
Yes.
redness, photophobia. He'll just complain with dull aching pain and loss of vision. Okay, it can also be high IOP. We just had a case before
Yes,
this.
sir. Yes, sir.
IOP.
Yes,
Okay,
sir.
post PK,
Post PK
can inflammation in the anterior chamber. Then you're starting immunoprednisolone acetate. Okay, so it can cause.
raised pressures.
Ah,
Yes, sir.
next.
Going on, personal history personal history and family history is within normal limits. General physical examination, the patient was moderately
Try
built
to
and
explain it. Try to tell that.
okay.
And go ahead. And here, because of shortage of time, we'll go fast.
Okay,
Something.
sir.
Okay. Yeah, within normal limits is what.
I'll continue with the general physical examination. I'll
What
explain
is
some.
general physical
Yes.
examination?
The patient was moderately built and nourished, conscious, well-oriented to time-place person. Pulse rate was 74 per minute, regular and good volume. Respiratory rate 16 per minute. BP was 120 by 90 mm of Hg. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Systemic examination, all systemic examination was within normal limits.
Okay.
Coming on to the ocular examination, head posture was normal, facial symmetry was normal, ocular alignment was normal. The right eye visual acuity was counting fingers 1 meter, and left eye distance unaided visual acuity was 6/9. Near vision could not be elicited in right eye because of the poor vision, and left eye near vision was N24. It was improving to N6 with plus 2.75 diopter. So can I share the picture?
Okay.
Okay, so going on for the with the ocular examination of the right eye, lids and adnexa, there is mild lid edema present. Conjunctiva has circumciliary congestion present. Cornea, coming to the corneal graft, it is an 8 mm central corneal graft. On diffuse illumination, the graft appears hazy and edematous. On a 2 mm slit examination, the graft shows the presence of diffuse stromal edema involving almost the entire graft with presence of endothelial keratic precipitates. Coming on to the host cornea, the host cornea shows superficial vascularization present from 3 o'clock to 5 o'clock, also present at 7 o'clock and 11 o'clock. Coming on to the graft host junction, there are 14 interrupted well-opposed 10-0 nylon sutures present. There is no suture infiltrate, ectasia, or leak seen. Vascularization from 3 o'clock to 5 o'clock is noted to be crossing the graft host junction. Graft host junction seems to be well opposed. Going on, anterior chamber has a grade 2.
We'll just try to repeat.
Yes, sir.
And try to tell everyone that whenever there is a case of keratoplasty presented to you, just like how you present a case of cornea where you start with diffuse illumination and a slit lamp illumination from the anterior epithelium till the endothelium.
Endothelium, yes, sir.
Okay, the same thing has to be done. Same thing has to be done. The only thing that gets added here is you have to tell the graft separately. You're supposed to comment on the host separately. Again,
Yes,
start from and epithelium till the endothelium, oblique and slit lamp, and then the graft host junction along with the sutures.
Yes, sir.
Okay. So this is how you're supposed to proceed whenever there is a case of keratoplasty. You're supposed to tell the size of the graft, which is very much obvious, and also on gross examination or oblique illumination, you're supposed to tell whether the graft is central, paracentral, whether it's a kind of a patch graft, whether it's kind of a banana graft.
Yes, sir. Full thickness.
Yeah.
central full thickness
Oh, good,
corneal
yeah.
graft.
I mean, it's quite tough to make out sometimes between a full, if in a graft edema to between full thickness and bulk anterior, but still can comment as full thickness.
Yes.
Okay. It has got the, that many sutures. And also in this case, I don't know whether the photo is being taken from this side or the patient is looking to the side, but looks slightly decentered,
Yes, sir.
the graft. Okay.
Yes,
And
sir.
also, you should also comment on whether like this is an 8 mm graft, and why are we commenting? Why is it important?
The size of
Size
graft,
of the
sir.
graft, yeah.
Uh,
What happens if the size is large?
so more chances of rejection if the graft is large or eccentric.
Yeah, why?
More actually more endothelial, more exposure to antigen basically. Uh, the rejection for rejection more.
Okay, basically the Langerhans cells that are there in the periphery get exposed to the antigen system better in a bigger way. Okay, even here if you see the graft there looks more decentered, or it's not that, I mean slightly decentered. This is right eye, right?
Yes, sir, right eye.
More nasal, and that is where the more closer it is to the
More
limbus is where it is attracting the vasculature.
vasculature. Yes, sir.
Okay, right. So, and KPs, what did you tell about the KPs?
Endothelial keratic precipitates. So they, I should have said that they look fresh endothelial keratic precipitates, and few of them are
Right.
pigmented as well.
Yeah. So fresh precipitates, if possible, the number and place which they where they are.
Yes, sir.
Why is it important?
Sir, if it is any recurrent HSV keratitis, the precipitates will be seen more towards the graft host junction.
Okay, and not of the graft or junction. Basically, you want to tell where the keratic precipitates are. Whether the keratic precipitates are there, of course, on the graft or it's on the host. If it is on the host, it tells that it is something related to the old disease. Any
Old
kind of
is
fresh keratic precipitates on the graft as such is an indication that there is some reaction going on against the graft.
yes, sir.
Okay. So what are all those loops sort of a thing? Probably artifacts.
Yes, sir. The artifacts.
Okay. Can I see this thing?
The
Diagram?
diagrams. Yes, sir.
Because you are supposed to show only the corneal diagrams in the
Yes.
exam. Something you want to improve here. You have drawn a circumcorneal congestion, you have done a graft.
Yes, sir.
Okay. There has to be another circumferential line here
Like
to depict the
the
cornea.
host,
You have not
host
depicted
cornea.
the host cornea here. You have depicted only the graft.
Graft, yes, sir.
Okay, there is no host cornea here. Okay.
Yes, sir.
Second thing, your description says there are 3 clock hours of vascularization and one vascularization
Yes,
at
sir.
7 o'clock near
And
the
11
suture,
o'clock.
and one is crossing the graft host junction.
Yes, sir.
Both things are missing.
Yes, sir.
Okay, because your photo will not be there.
Yes, sir.
As soon as I look at this, I should be able to imagine what all things are going on in the eye.
Yes, sir. I'll add
Okay,
that.
so you need another circle to depict the host cornea and the
And
vascularization.
so vascularization, sir.
And definitely the vascularization. Exactly.
Yes, sir.
Okay. Yeah. And always, if there is another anterior segment findings, for example, if there's an hypopyon,
To be depicted in the
you draw another diagram depicting the anterior chamber findings separately. Don't try
Yes.
to merge your hypopyon within this same photo. Don't
Yes.
try to push in hypopyon here only and show that it's hypopyon. You draw
Yes.
another diagram here, draw anterior segment findings separately. On a slit, you can always show it in a single
Yes, sir.
picture.
Yes, sir.
Okay.
Like
Yeah.
you can make another slit and show the side
You can
view.
always show. You can always show another slit. Slit, you can always show it in a single photo because it's a
Yes.
slit. From anterior till the IOL, you are able to see everything.
Yes, sir.
Okay, but whereas when it comes to anterior posterior picture, you'll always draw the corneal findings separately. Be it even in a case of ulcer, for example, you will draw the infiltrate, corneal edema, scar separately.
Yes, sir.
Then you will draw another diagram depicting your hypopyon
Hypopia. Yes,
or
sir.
hypema. Could be anything, any kind of anterior segment changes.
Okay, sir.
Right. You got to improvise. You have to draw. You cannot be thinking in the examination what was the color, how to draw, what to draw. You have to keep doing it for your 3 years or 2 years when you're in your clinics. So that they should be at your spinal level when you're drawing your diagrams in the exam, both cornea and retina.
Yes, sir.
Right.
So going on to the completing the examination of right eye, the anterior chamber had grade 2 flare. AC reaction could not be made out because of the corneal edema. Pupil 4 was 4 not reacting to light. Lens PCIOL was present. IOP was digitally normal. Fundus with distant with direct ophthalmoscopic examination was done.
You want an instrument, which instrument you can use to depict an IOP?
Uh,
Of course, GAT is not possible.
no,
Which one? You can use an eye care if I give
eye
you.
care. Huh.
Huh?
Yes, sir. Eye care can be used.
But still digital
Uh,
tension is good enough. Right.
okay, sir. Fundus examination, a direct ophthalmoscopic examination was done with a plus 20D lens. Fundus was hazily seen, disc appeared normal, macular details could not be made out due to the corneal edema. Uh, Going on to the ocular examination of left eye, lids and adnexa are normal, ocular movements full and free, conjunctiva was normal, cornea normal in surface, shape, sheen, transparency, and sensations. Anterior chamber was normal in depth and quiet. Pupil was 3 round, regular and reacting. Lens status, the patient had a PCIOL in the left eye. IOP done with Goldman applanation tonometry at 10 a.m.
Yeah.
in
So left eye
10:30 a.m.
was, yeah, we'll just
was
keep moving ahead with the discussion.
yes, sir.
Right.
Left eye was normal in
Yeah.
presentation.
Then,
Sir, so moving on, my provisional diagnosis will be right eye post-therapeutic keratoplasty with acute graft rejection and left eye having pseudophakia. But with this, sir, I would still want to keep differentials of infection and endophthalmitis in mind and would like to do a B scan to rule out endophthalmitis.
okay, good. So you can always tell what you need. Because the next question would always be what all investigations you want to do. Okay. So looking at your picture as such, chance of infiltrate or repeat infection just gets ruled out.
Yes, sir.
Okay, now, and one more thing I want to add is always at the end of your case, before your provisional diagnosis, try to have all the positive findings in one line.
Okay, yes, sir.
Which is going to help you in coming to your diagnosis. Okay.
Okay, yes, sir.
Farmer by occupation who had a trauma with sugarcane, developed probably an keratitis,
Yes, sir.
had a surgery for that. He was all right for 4 months, then developed sudden onset 7 days back. Okay. So probably suggestive of
suggestive of acute corneal graft rejection. Then, sir,
graft rejection is a subdivision.
okay.
What has happened? What has happened to the graft? What do we call acute graft rejection? Is one of the causes of
Failure, graft
exactly.
failure.
Exactly.
Yes,
this is a primary or secondary?
Secondary graft failure.
What is primary?
So primary, the graft will never clear. Like the graft edema will be there since day one. The graft was clear and the patient was the vision was improving. and the edema came later on. So it's a secondary failure, sir.
It's a secondary graft. Secondary
Uh,
graft failure, probably
yes,
because
sir.
of acute
Ac-
graft.
Acute graft rejection.
What are the points in favor of acute graft rejection?
Sir, Cornell, basically in history, there is pain, sir, painful
Ah.
diminution of vision.
Hmm.
Secondly, there is corneal edema with keratic precipitates and flare, which tells us about the inflammation.
That's
Um,
what. Why I asked you that is now your next part of the diagnosis will be you said graft failure, probably because of acute graft rejection. Where is the graft rejection? At what level?
Sir, endothelial, endothelial actually,
Endothelial.
endothelial.
Probably an endothelial graft rejection.
Graft rejection, yes.
Okay. Why did I use the word probable and not definite? So how do you tell that definitely this is a graft rejection, endothelial graft rejection, or probably this is a graft rejection?
Uh,
There is a term when we try to
yes, sir.
talk about rejection, we always try to differentiate between whether it is a definitive graft rejection,
Definitely.
a probable graft rejection,
Probable.
or a
Yes.
possible graft rejection. So what?
Sir, definite graft rejection if the classical appearance of rejection is the Khoda dos line and all is
Exactly. The
present.
first line has to be there. So what is it?
Sir, it's basically they are keratic precipitate starting from the graft host junction and progressing to the central cornea with overlying stromal edema.
Those things, along with anterior chamber reaction,
Anterior chamber
circumponent
reaction.
illusion, diminution of vision, whatever becomes.
Definitive
If you don't have a corridor line, then it becomes probable.
probable graft
Yeah.
rejection.
If you have only diminution of vision with no signs of inflammation, possible.
Possible, yes, sir.
Something would have happened. Okay. So I think our next examiner will be waiting. So quickly now tell me, how will you manage this case?
Sir, we'll start the patient on we'll start the patient on steroids, and the patient has
One thing I want to add is, sorry to interrupt. One thing I want to add is, in spite of steroids, patient can still have rejection.
yes, sir.
Okay, patient can still have rejection even on being on a steroid.
Steroids, yes, sir.
Okay, sometimes even tapering causes it to flare up. It can
Flare.
have once a patient was on a graft, then he is a candidate for rejection all the time.
All the time, yes, sir.
Okay. So considering so how will you manage? Then I'll tell you the probable things you need to remember also. Yeah.
So we'll start the patient on topical steroids with good penetration, like topical prednisolone 1%.
Yeah.
With that, sir, he's
How
present.
many times?
Sir,
Supposed to
1
give a
hourly.
complete prescription in your exam.
Yes, sir.
It's not prednisolone acetate 1%. How many times? Everything
Yes.
is to be told. Yeah.
So we'll start the patient 1 hourly for around 3 to 5 days, and slowly taper the patients over months.
First,
Uh,
your first job is to start using steroids immediately, 1 hourly.
yes.
Okay. And then got to monitor how he responds and accordingly try to taper it. One.
Taper.
Okay. Then
And so patient has presented in a week, so you can start him on oral steroids or injectable steroids. They say that a single dose of injection methylprednisolone is beneficial. So systemic corticosteroid should also be started,
yes.
especially if the patient has presented within a week. It's said that injection methylprednisolone single dose is beneficial, and then you can give oral
Oral. Oral how much? Which
prednisone
one?
for a week and
Oral.
continue on topical steroids.
Okay.
A week and taper the oral
Oral
steroid.
also has to be tapered over a period of other 5
Period
to
of
6 weeks.
yes, sir.
Then you have steroids. Steroids is the one that starts tapering after 5, 6 months, 8 months.
Yes.
Okay. Along with that,
Along with that, sir, we'll continue the antifungal medications for him, which also were stopped.
Okay.
Um any
And AGMs and homide.
Yes, sir. Homemade
Those things.
lubricants.
Okay. What about immunosuppressants? What are the indications for immunosuppressants?
Sir, if the
Name a
patient is
few.
intolerant or the steroids are contraindicated, then we can start. If the patient has an epithelial defect with along with this, which is not healing, then we'll have to switch.
There are few things where you have, I mean, it is indicated. Like, so if you want to answer that, then you need to know what is a low risk graft, what is a moderate risk graft, what is a
High risk
high risk
graft.
graft. So what are those cases?
Sir, high risk grafts are
Any on
basically
etiology? Yeah.
any on etiology, any graft done for any infectious causes, any regrafts,
Another thing
repeat.
becomes moderate. This high risk is something that is more than 50% chance of rejection. So these are all your inflamed eyes, Stevens-Johnson syndromes,
Uh,
cicatricial conjunctivitis, burns, acid burns, lime burns,
chemical injuries. Yes.
exactly. Those are the things where, and those are the conditions where you want to use uh,
Uh,
immunosuppressants.
Immunosuppressants.
Yeah. Name, can you name a couple?
So cyclosporin A is
Okay,
given.
cyclosporine,
Mycophenolate, mofetil, and
stimulating.
azathioprine is given.
Exactly. So those things can also be added, but of course, with the help of your rheumatologist.
Yes, sir.
Okay. Now, if it's a herpes patient, what was another thing you want to add?
There can be recurrent herpes infection in this. So we'll add antiviral, basically eye ointment, uh, this thing. I forgot the name.
Yes, I know.
Acyclovir,
There
3%.
is one ointment on this earth and you forgot that name. Okay.
So if we are suspecting a recurrent herpes infection, and
How
if
do you
we
know it is recurrence or it is a fresh infection in a graft?
Sir, recurrence can be epithelial and stromal also. Epithelial sometimes they come with the dendritic ulcers, but
No.
stromal and endothelial are more or less confusing.
Now,
So
basically, no. If it's a recurrence, it is usually at the graft host junction or the host
Yeah,
basically.
yes, sir. And this is more central.
Infection in a graft that never was herpetic can have an herpetic infection in a graft as such because that eye is now prone to an herpes infection
Yes,
because
sir.
of your steroid use or because it's an inflamed or all those things. Okay.
Yes, sir.
In that case, of course, in any kind of herpes you try to operate, you want to give a acyclovir,
Acyclovir
400 mg twice a day.
twice a day.
If it's a quiet eye, non-emergency, start a couple of months before and try to continue 6 months to 1 year later. Some
1 year
people
later.
2 months.
Yes.
Whenever you tell about acyclovir, you should always tell that you need to do a kidney function test regularly.
Yes.
Okay, so you need to know what is a high risk graft, indications of what are the etiology that causes a high risk graft, etiology that causes a moderate risk, etiology
Moderate
that
risk.
causes a low risk
Low
graft.
risk graft.
Okay, and also you need to know depending on vascularity, which is
Yes, sir.
low risk, moderate risk.
So low risk, more than 2 clocker of vascularization goes in favor of high risk graft. 1 to 2 is moderate, and less than 1 or no vascularization is low risk.
No vascularization is low risk.
Low
So any
risk.
graft is always at risk of rejection.
Yes.
Okay, so you also need to need the definition of what is graft rejection.
Yes, sir.
What is primary graft
Graft.
failure? Yeah, what is secondary graft failure? Causes for primary graft failure, causes for secondary graft failure.
So primary graft failure is basically when the graft
No,
does
I'm
not.
telling you the questions which you need to
Yes.
know. Okay, so what is a high risk graft? What is how is the vascularity going to affect your risk for rejection? Okay,
Yes, sir.
and of course the management.
Yes, sir.
Hmm? Right? I think
Yes, sir.
we're already 8:45 now.
Yes, sir. Thank you, sir.
Yeah, yeah. So, Dr. Deepti?
Yes, sir.
Yeah, madam.
So with this, we wrap up our cornea case presentation today. And next we have with us Dr. Shanmugapriya. She would be presenting a case of PDR. I think every exam will have a case of PDR. That is the most common retina case which is found everywhere. So she would be presenting a case of PDR which VH, and we have with us as the examiner Dr. Giriraj Vibhuti, who is our retina consultant at MM Joshi Eye Institute. Over to you, Dr. Shanmugapriya and Dr. Giriraj.
Good evening, everyone. Can I share my screen, ma'am?
Yes, Shanmugapriya, please share.
Mr. Y, 55-year-old male, a teacher by profession, came with complaints of diminution of vision in both the eyes, right eye more than left eye, for both the distance and near since 3 weeks. History of presenting illness, diminution of vision in both eyes, right eye more than left eye for both distance and near since 3 weeks, which was gradual in onset, painless and progressive in nature. And history of floaters in right eye. And no history of flashes of light, no history of distortion of images. No history of redness, pain, watering and discharge, and no history of usage of thick glasses. Ocular history, no history of any ocular surgeries or laser treatment in the past, and no history of trauma to the eye. Medical history, he is a known case of type 2 diabetes mellitus on medications in 7 years. Family history is not significant. And personal history, sleep appetite is normal, bowel and bladder habits are normal, and no history of any addictions. General physical examination, he is a middle-aged man, moderately built and conscious, cooperative, oriented to time, place, and person. His vitals are with a pulse rate of 82 beats per minute and with a blood pressure of 140 or 80 millimeters of mercury, and no pallor, icterus, cyanosis, clubbing, and lymphedema.
Can you stop here?
Yes, sir.
At the end of history, you should always think what is your differential diagnosis with this data. Whatever data you have presented till now,
Okay.
55-year-old male who has diminution of vision in both the eyes, one eye more than left eye, he is a diabetic, and systemic examination, all you told. So what do you think could be the cause for vision diminution of vision? What was the vision? You did not tell the vision.
So vision next in the examination part.
You can tell now.
Okay. The unaided distance visual acuity in right eye is 5/36 and in left eye is 6/18. Unaided near visual acuity in right eye is N18 and left eye is N6. With acceptance, right eye is not improving, and left eye with acceptance with plus 0.75 spherical and with plus 0.5 cylindrical at 80-degree axis, it is improving to 6/9. And with an addition of plus 2.25, he is improving to N6.
Okay. So with this history, what could be your differentials?
So he's a 55-year-old male with a gradual in onset and progressive in nature with a painless diminution of vision. So based on this anterior segment, he can have cataract, and he can have in posterior segment, it could be diabetic retinopathy, hypertensive retinopathies, and age-related macular degenerations.
Okay.
It can be.
Okay. In addition to that, any vascular occlusions you have to keep in mind. While asking for any history, you have not mentioned any of the drug histories or what medication he has taken in the past or any surgeries in the past. It was not mentioned.
Okay, sir.
Okay, so come to the history first slide. Yeah, the next slide. So floaters, is it relevant in the case? Because everybody knows you are presenting a PDR case. I'm asking retrospectively to save time. So do you think floaters are important, and why? You can tell quickly.
Yes, sir. Floaters are important. If there is a vitreous hemorrhage, patient will complain of floaters.
Okay, fine. Vitreous hemorrhage
And
in case.
if there is any vitreous.
Yeah. And in addition to that, the 55-year-old patient, they may have PVD. PVD itself can cause floaters. So that could be a differential diagnosis. And PVD itself could be a cause of vitreous hemorrhage if vitreous hemorrhage is there. So it is not necessary that a diabetic patient should always have proliferative diabetic retinopathy. Okay. Flashes, is it relevant?
Yes, sir. He can in PVD also there might be flashes of light, and in case of any retinal tear also the flashes of light can be present.
Yes. Again, retinal tear it can be a cause for vitreous hemorrhage, floaters, diminution of vision. Okay. Distortion of images.
Metamorphopsia can be seen in case of central serous chorioretinopathies. And
At 55 years, would you
no,
suspect
no,
first
no,
thing?
no. It is seen in
Diabetic
middle-aged
patient, first thing you
persons.
can suspect could be a macular edema, isn't it?
Okay.
Which can cause metamorphopsia, or a presence of an epiretinal membrane, which can cause metamorphopsia. What is micropsia? Micropsia, you know?
Yes, micropsia is the object image size will be smaller in size when compared to the same. Macropsia it will be of larger size.
Fine. Find its relevance later. Okay. Then history of redness, watering, pain. So you mentioned this patient had gradual, painless, progressive loss of vision, isn't it?
Yes, sir.
So in diabetes, can the vision loss be painful?
Yes, when there is a neovascular glaucoma associated,
Yeah,
it could be
because of
painful.
neovascular glaucoma, the vision loss might be painful.
Mm.
Fine. History of any uses. Why did you ask for thick glasses history?
To rule out any history of myopia is there, which can result in a break.
Okay. Any correlation between myopia and diabetic retinopathy?
I'm not sure, sir.
Myopics will have multiple patches of chorioretinal atrophy, thinned out retina. I'm giving you a clue. Any conditions which patient can have in which the patient is relatively immune to development of proliferative retinopathy?
Sir.
Retinitis pigmentosa, high
Okay.
myopia. Today morning only,
Yes, yes.
isn't it? So,
Yeah.
fine. Okay, fine. So go to the next slide. No history of trauma. Okay. Again, you have not mentioned about drug history. Any anti-diabetic medications which itself can cause diminution of vision?
But thiazolidones.
Yeah, all the glitazones, rosiglitazone, pioglitazone, they are known to cause macular edema, and they by themselves can lead to diminution of vision. Any other drug history you would want to ask in a patient who is diabetic, who might be, what do you say, his immune system might be compromised, he is susceptible to other infections and all? So I'm guiding you towards history of anti-tubercular therapy in the past,
Okay.
because you have not mentioned any drug history.
Okay, sir.
Okay. Again, any other medications which can cause cystoid macular edema, that could be a question.
Okay.
Fine. Next slide.
So,
Okay, fine. Next slide. So yes, this BP control and this no pallor icterus cyanosis, why is it relevant in this case of PDR?
if PDR is associated with diabetic nephropathy, patient can have pedal edema.
Yeah.
Clubbing.
So facial edema, not just pedal edema. First thing
Facial
is
edema.
puffy eyes. So that is the first onset. So patient might not be knowing that he is having a nephropathy also. There is a strong correlation between diabetic retinopathy and diabetic nephropathy. Many of the times you could be the first person who will diagnose that he is having nephropathy also. Why pallor?
Anemia can also present.
Anemic retinopathy can also present with features which can mimic diabetic retinopathy features. So it might be a confounder for you. Okay. Yeah. Okay. Next. So when a patient walks into your clinic, initially you have to look overall at the patient as a whole. Then you might get other clues that he might be having a diabetic foot, he might be having a plastered toe or a plaster over the leg. So there might be some amputations. So it means that overall the control is not good. Is it relevant here to ask in the history that whether his sugar control and BP control and all has been good or not? Is it relevant?
Yes, sir.
How?
Because if in an uncontrolled diabetes mellitus, a patient can present with what you said, like amputation of leg or any.
You will ask for control of diabetes just to know whether patient is amputated or not?
No, based on that also we can predict.
It means you don't know. Better control is correlated with prevention or protective from worsening of diabetic retinopathy. So because you have not given answer to this, I don't think you will answer the question. Which study told you that better control of is?
Diabetes control and complication trial study. And
Yeah.
UK NDP study also has it.
What?
UK NDP
Yeah.
study unit.
UKPDS.
UK PDS study.
Okay. Yeah, fine. Next.
Right. Ocular
Why head
examination.
posture? Yeah. Why head posture is and facial symmetry is relevant?
Sometimes diabetes can affect the extraocular muscles, and patient might present with lateral rectus palsy also.
Okay, fine. Yeah. That point I wanted you to know. Yeah. Then next.
Head posture erect, facial symmetry symmetrical, ocular alignment normal, ocular movements full and free in all gaze.
Next. Yeah.
Coming to anterior segment examination, right eye adnexa normal, conjunctiva normal, cornea normal in shape, size, luster, transparency, and sensation. Iris normal in color and pattern, no neovascularization of iris. Anterior chamber normal in depth and contents. Pupil round, regular, reactive to light, no relative afferent pupillary defect. Lens posterior subcapsular cataract. And intraocular pressure measured by Goldman's applanation tonometry at 11 a.m. is 15 millimeters of mercury. Coming to left eye, adnexa normal, conjunctiva normal, cornea normal in shape, luster, transparency, and sensation. Iris normal in color and pattern, no neovascularization of iris. Anterior chamber normal in depth and contents. Pupil round, regular, reactive to light, no relative afferent pupillary defect. Lens nucleosclerosis 2 with posterior subcapsular cataract. Intraocular pressure of is 16 millimeters of mercury.
Okay. Sensations, is it relevant in this case?
Yes, diabetic neuropathy will have reduced sensations, corneal.
Okay. Any other corneal condition which they are prone to? Like dry.
Corneal ulcers.
Anyways, sir has discussed. Let's go to the next slide. Posterior cataract and yeah. Okay.
This is the fundus image of the right eye. With a distant direct ophthalmoscopy, there is a good glow. This is examined with an indirect ophthalmoscope with a 20D. Media is clear. With the disc appears to be normal in shape and size with a vertical cup disc ratio of about 0.4 and arterial venous ratio is 2:1. And there is a fibrovascular proliferation over the disc and along the superior nasal arcade. And there are multiple dot blot hemorrhages and hard exudates seen in the posterior pole. And the macula, there is a hard exudates around the macula with FR is dull. And inferiorly,
Where is the hard exudates? I don't see any hard exudates in the macular.
that yellow thing is.
Okay, fine.
And inferiorly, vitreous hemorrhage is seen.
Okay. You said distant direct ophthalmoscopy is normal, but you have mentioned posterior subcapsular cataract there. Do these two things correlate?
No, in with a PSC, there will be a central dark shadow will be seen with distant direct ophthalmoscope.
Yeah, and the fundus picture will not be so clear. So it means either the cataract is not so significant or you have misdiagnosed the cataract, isn't it?
Yes.
Fine, okay. What is NVD? When would you call the patient to be having NVD?
So when there is a neovascularization over the disc or within 1/3 of the disc area.
1/3 of the disc area.
Oh, that is one of the criteria for high risk PDR.
Yeah, now you have brought the topic of high risk PDR. Okay. First tell this and then tell the characteristics of high risk PDR.
Neovascularization is over the disc. And
within one disc diameter from the disc.
disc diameter.
Yeah,
And,
tell me high risk characteristics.
High risk PDR is neovascularization of the disc involving 1/3 of the disc area or NBD associated with vitreous hemorrhage or neovascularization elsewhere involving half of the disc area with vitreous hemorrhage.
Neovascularization elsewhere?
With involving half of the disc area with
neovascularization elsewhere can involve
no,
the disc.
No.
Then what are you speaking?
Yeah, NV is with VH, I think.
Okay, fine. So vitreous hemorrhage is there and Anything else do you think? Is there any vascular tortuosity here? The venous tortuosity?
Mild tortuosity is there.
Okay. Would it be a mixed retinopathy rather than just PDR?
But other features like cotton wool spots and flame-shaped hemorrhages are not there.
And patient is not a hypertensive and
Not
you
a
have checked the
hypertensive.
BP. You have checked the BP, no? I think you
Yes,
have
sir.
mentioned.
Yes, sir. It's normal.
Fine. Yeah. Okay. Fine. Go to the other eye.
So Amsler
Okay.
chart of that
Hmm.
right eye.
Okay. Hmm. Fine. You couldn't see till the aura because your
No,
vitreous
sir.
hemorrhage is till mid periphery and then suddenly it has stopped. Is it
Okay.
possible? In this diagram, you
No.
have it only till mid periphery and then there is no vitreous hemorrhage suddenly.
I didn't indent and see.
Suddenly the vitreous hemorrhage will not stop like this, no, like exact in
Okay.
circular fashion. So this diagram
Okay.
is not right.
Okay, sir.
Then fine, hard exudates, okay, macular edema, okay. Yeah, can go to the next slide.
This is this is a fundus picture of left eye. A media is clear with a cup disc ratio of around 0.3 with a healthy NNR and arteriovenous ratio of 2:3. And there are NVEs seen along the superior-temporal arcades and the inferior-temporal arcade. And there are fibrovascular proliferation seen along the superior arcade. And macula is multiple dot blot hemorrhages. I'm sorry. Multiple dot blot hemorrhages are seen in the involving the posterior pole, macula normal and FR plus.
Okay. Why do you say it is an NVE? Based on the fundus picture alone, I can say it is an IRMA. How do you differentiate between those two?
IRMA is a intraretinal microvascular anomaly, which are basically an arteriovenous stunt. IRMAs do not cross the horizontal meridian. And NVEs will cross the horizontal meridian, and IRMAs will be a little bit deeper, and NVEs are superficial, and their branching pattern will be seen. And IRMAs usually do not bleed. NVEs will be bleeding.
Okay, and NVEs will be slightly elevated.
Elevated.
Yeah. So, okay, I would want to say this is, if this was a severe NPDR case, what is the criteria to say severe NPDR? What is 4-to-1 rule?
4 quadrants of hemorrhages should be there, and 2 quadrants of venous changes, and 1 quadrant of IRMA should be there.
Okay, fine, good. Then, okay. Is there any relevance of disc pallor in cases of diabetic retinopathy or PDR?
Yes, sir.
How?
It could be associated with AION or something.
Not AION. Non-arteritic AION.
Non-arthritic AION.
Yeah. So in addition to that, diabetic papillopathy itself can be a cause for optic disc pallor.
Yes, it could be.
Okay, fine. Okay. Then what is your diagnosis?
Oh, sir, this.
Yeah. Okay.
My professional diagnosis is right eye senile
The
immature
professional
cataract.
diagnosis or provisional diagnosis?
Provisional diagnosis
Okay.
is right eye senile immature cataract with proliferative diabetic retinopathy and vitreous hemorrhage. Left eye senile immature cataract with proliferative diabetic retinopathy.
There you have mentioned PSC, no? If you can be specific, you can mention posterior subcapsular cataract.
Okay.
With
Okay, sir.
proliferative diabetic retinopathy and vitreous hemorrhage. And you said hard exudates at the macula and no FR in the right eye. Then here you have not mentioned anything about it. So
OCT was showing.
you have not shown me the OCT, right?
Okay, sir.
You
But
have come to
clinically,
the
it
diagnosis.
suggests
So
of
clinically, what is clinically significant macular edema?
retinal thickening involving the 500 microns of the center of the macula and the hard exudates involving the 500 microns of center of macula. It could be associated with retinal thickening or outside. And retinal thickening can be of 1500 microns from the center of the
Clinically, you
macula.
will see 1500 microns.
No.
Yes, you can. You should say how.
Sure,
What
sir.
is the size of the disc?
1500.
Then,
Okay, comparative with the disc.
yeah, compare it with the disc diameter.
Okay.
So, yes, okay, that is the diagnosis. Because you mentioned there are hard exudates and no FR in the right eye, I would like to think that there might be some macular edema, isn't
Okay.
it?
Yes, sir.
So, yeah. So, what would you like to do with this patient? 5/36 in the right eye and left eye improving till 6/9, I guess.
Yes, sir.
So, what would you do next?
Sir, I'll for investigations. First, I will go for RBS and HbA1c level to know about his glycemic control.
So, patient is in front of you. You will send the patient first to get the blood levels, or would you do something else which is
No,
there in the next room?
OCT first we'll do.
Yeah, you should do your investigations first, no? Before sending
Mm.
out, will you call the patient back?
Okay,
So, yeah.
OCT we will do.
Then you
Then
have the
these.
OCT of this patient.
Yes, sir.
Okay. So, describe the OCT.
OCT. This is a OCT of a right eye showing a vitromacular interface looks normal, and there
Clear
is
media.
a media clear, and there is a hyper-reflective layer, which is suggestive of a hard exudates.
Layer,
And
is it?
But you said it's a
hyper-reflective.
vitreous hemorrhage. The
Okay.
media is clear.
Yes.
Your diagnosis says vitreous hemorrhage, so you have not qualified that vitreous hemorrhage. Is it a partially absorbed vitreous hemorrhage? Is it a resolving vitreous hemorrhage? A fresh vitreous hemorrhage? Is it a total vitreous hemorrhage? So
It
with
looks
that,
like
whatever 5/36 vision you said, like say 660, is the how much is the cataract that is significant? I think in this very important thing is even before you really look into the all these details, if you have an advanced cataract with the PDR, then if the amount of cataract matches the 6/60 vision, then you expect that the retina is not that bad. If the cataract is very early and there is no refractive error, even then the vision is very poor, then obviously something is wrong at the macula, right? So you have to get these indirect evidences. You can't only be relying on OCT. So clinically, the amount of cataract should always match the vision loss. Okay. So in a real case, you need to actually go for it. Hmm? Right.
In this case, is it matching? Because OCT shows clear media, your vitreous hemorrhage is only inferior, and there is no macular edema. Would this correlate with the 5/60 vision which you have given?
no, sir.
Then is
On
cataract
picture, it
significant?
looks like resolving vitreous hemorrhage.
So there might be other causes, no?
Mm.
What are the other causes then which you can think of? That is
So
again
with
another.
this OCT, with this retina, with this macula, with early cataract, how do you explain additional vision loss? That's what Dr. Giriraj is
Yeah.
asking.
It could be associated with any other vein occlusions underlying.
No, no, you're seeing no retina, you're seeing the retina.
Metals.
No, no, something which you can't see but only presume. See, vision, central vision is basically macula. Okay. Whatever happens in the periphery, you don't have to bother. Macula is something. So if you say here, like your histopathological cross section, as if in an OCT, looks fine. Okay. But something may be going wrong in the macula, no, which you can't see on the OCT, which probably you will have to do some other investigation to find out. What is that?
Ischemic maculopathies.
Yes.
Hmm.
So
Can
now
do
the blood
FF.
flow started. Okay.
So what will you do next if required for that?
A fundus fluorescent angiography we will do.
So what are the features of macular ischemia on fundus fluorescein angiography?
Not sure, sir.
Huh?
I don't know, sir. We'll read.
You should know, na? This is not very difficult. Capillary dropouts, will you see?
Capillary dropouts will be there.
Then something will be
Well,
enlarged.
leakage,
Something will be enlarged.
CNP areas. Sorry, foveal avascular zone will be
Yeah,
enlarged.
foveal avascular zone will be enlarged. Its shape will be irregular,
Mm.
isn't it?
Yes.
So what else you would get to know on FFA?
We can when we are in doubt, we can differentiate NVEs and IRMAs in FFA.
How?
There will be no leakage with IRMAs,
Mm.
and NVE will show late leakage.
Then what else will you see?
The CNP areas can be seen.
Okay. Then what else?
Then in case of other indications like when there is a dense asteroid hyalosis, also we can do FFA.
Fine. Okay. In addition to that, you can get to know what is the arm retina time, isn't it? PDI
Okay.
could be another differential diagnosis could be ocular ischemia.
Okay.
In delayed
Yes,
arm
sir.
retina time, again you can suspect that.
Okay.
Okay. Then yeah, because you have brought this patient, and now how will you manage this patient?
I will do if I suspect clinically significant macular edema is there, then I will give
Just now
anti-VEGF.
you said no,
But okay.
and you have confirmed it on the OCT.
OCT shows no.
And all you're saying, or whatever discussion is going towards macular ischemia, then would you still want to give injection of anti-VEGF?
No, sir. If there is a macular edema only, we will give anti-VEGF. Otherwise, we will do PRP only first.
Okay. So in this patient, you would like to do PRP.
PRP first.
Okay. Would you like to remove the PSC or do a cataract surgery?
If the vision is poor, we are not able to visualize the media properly, we remove the PSC first and then we can go for PRP.
In this patient, you have seen the patient.
Yes, sir. But
Fine. The next question would be, is there any like correlation between cataract surgery and diabetic retinopathy?
yes, sir. The cataract surgery will result in lot of inflammation and which can
Lot of
further
inflammation. You do bad cataract surgeries.
it might result in inflammation which can further aggravate diabetic retinopathy.
Yeah, it is known that diabetic retinopathy may progress after cataract surgery. So before that, you would like to do PRP to the extent possible, isn't it? So
Yes.
what study gave you the role of PRP in diabetic retinopathy?
So one protocol yes study has shown that
Don't mention protocol S. You are going in the wrong direction. We are talking about PRP. It is like one of the first study. Role of laser in diabetic retinopathy.
forgot the names.
Diabetic retinopathy study. Name itself.
Diabetic retinopathy study.
Yeah. Then what are the types of laser which can be done in patient of diabetes?
One is pan-retinal photocoagulation, then focal laser, grid laser.
Then when would you do focal laser? When would you do pan-retinal photocoagulation?
Focal lasers or only when there is a focal areas of lesion with the focal leakage.
Leaking
That time we will
microaneurysms, you can say.
microaneurysms.
Then when would you do grid laser?
Grid lasers we will do for diffuse leakage and
Yeah. Then when would you do pan-retinal photocoagulation?
in case of PDR, we will do pan-retinal photocoagulation when there are
Okay.
NVEs.
Okay, fine. Which quadrant you would like to do first?
Inferior quadrant is the first we will do.
Why?
Because if it bleeds, the visualization will be obscured, so it will be very difficult to do.
Fine.
The blood gravitates inferiorly.
What kind of laser do you use?
Argon laser.
Argon laser do we use?
Sure, sir.
In addition to that, what is the commonly used?
NDR.
Frequency doubled.
Okay.
What is the frequency?
With the energy of 200 millijoules and
Any
100 to 5.
Have you done any PRP, at least something? Do you know any about parameters of the laser?
Energy of 200 millivolts and time duration of about 0.05 seconds.
Okay.
And
What is Pascal?
it is an energy measurement. I'm not sure, sir.
Pattern scan laser is like you can do with the indirect ophthalmoscopy or slit lamp based, isn't it? Slit lamp based, you can do pattern laser, or it can be focal lasers again, spot laser. So pattern lasers, how they are advantages? Okay, anyways, we are going into details. Fine. Then what are the indications for surgery in case of PDR?
When there is any traction fibrovascular proliferation which is involving the macula and which is leading to traction.
Then
When there is a recurrent vitreous hemorrhage which is not resolving.
first tell no, the recurrent is not first is non-resolving vitreous hemorrhage.
Non-resolving vitreous hemorrhage.
Premacular vitreous hemorrhage.
Oh, yes, sir.
Subhyaloid hemorrhage.
Okay.
Then tractional retinal detachment involving fovea. Then
Combined retinal detachment also we can.
Then
Mm.
these are common indications. Tell some one or two. I just want like rare indications when you would want to do. You have mentioned that name earlier. Dense asteroid hyalosis, where you can't.
Dense asteroid hyalosis.
You did FFA, you saw there is PDR, but you can't do laser. What will you do?
We will do vitrectomy to remove that asteroid hyalosis.
Oh, you can give anti-VEGF. No, you have mentioned protocol F.
But
So yes, that is one of the options based on your OCT and FFA findings, or if there is vitreous hemorrhage or you have detected there is tractional retinal detachment, then obviously you would have to do vitrectomy in that cases. Last indication which you would should mention in the end is intractable macular edema.
Okay.
Okay. So about anti-VEGFs, what do you know commonly used anti-VEGFs?
Sir, ranibizumab, aflibercept, bevacizumab.
Okay.
Are commonly used.
Then
And others like brolucizumab, faricizumab.
Faricizumab, is it?
Faricimab.
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 Okay. So would you give anti-VEGF before planning your surgery?
Yes, sir. It reduces the bleeding intraop.
Okay. And when would you give it?
1 week prior to the surgery.
Why 1 week? Why not earlier or why not later?
For the anti-VEGF to act.
It is
The duration of the
recommended you should
action.
give it 3 to 7 days prior to the surgery. Okay. If you give it too early, then there is risk of what? If there is TRD, there is risk of something. What is that called when the something is a crunchy something? Crunch syndrome, it can happen.
Crunch syndrome. Okay.
Yeah, the fibrovascular membranes, they will contract and your TRD will worsen. And it will become difficult for you to operate. And you are worsening the diabetic condition of the patient himself. Okay. So how is diabetic vitrectomy any different from normal vitrectomy? So I will only tell you because it might be a little difficult for you. In diabetes, the main important point is there might be vitreous crisis. So your PVD induction and all will be difficult. So you have to keep in mind about multiple membranes. In addition to that, they might ask you about common techniques used in diabetic vitrectomy surgeries. What is segmentation? What is delamination? That is the question if you reach till this stage. Do you know segmentation and delamination? If not, I think we have crossed the time of half an hour. So if you don't know, you can read about it or we will discuss it next time.
Segmentation is cutting between the two pillars is called segmentation.
Okay.
Fibrovascular proliferation and
Delamination is where you are separating it from the
peeling.
underlying red.
Yeah.
Yeah. Yes, sir. I think we have.
Okay. So well presented, Dr. Shanmugapriya. Thank you, Dr. Giriraj, for discussing it at length about the most common case that is likely to come in the exam. I think it's just not for the exam. I think in real life also, diabetic retinopathy is a very serious condition which is increasing day by day. You should know. But one, before we wind up, for everyone, uh, you may not be presenting this to a VR surgeon sometimes. You may be presenting it to a comprehensive ophthalmologist. So then the questions will be more basic. They'll be more on the classifications and the things that you find in the textbooks, like what are the high risk characteristics, what is the definition of CSME. So there can be more about the most classical definition that you find in the books. Please make sure that you know it by heart and try to reproduce it without making any mistake, because that if you probably cross that, there will not be many more questions in that. At the same time, you should know how to discuss or describe the fundus finding. Okay, so you should know the exact words. And as I have promised, at the end of all the case presentations, we'll have one full session on all the routine fundus cases. That will be a masterclass by Dr. Guru Prasad, where you can interact with him, and also you can know exactly how to describe a particular finding and what are the likely questions that may come in the those discussion of those fundus photographs. So sometimes you may have it in the OSCE. In DNB, you know, some of the photographs can be OSCE findings, or they can even the examiners can keep a laptop, because you have table viva. They may show different fundus photographs or OCT images for discussing various retinal conditions. So get prepare yourself well for all the most common findings, and I think with this we will wind up today's case presentation. Dr. Deepti, are there? Okay. Then, so thank you all the panelists, Dr. Giriraj, Dr. Aniket Shastri, and all the presenters, the postgraduate students who have really done a good job. So hope this was of some use. So tomorrow we'll meet all of you at 7:30, again with another set of examiners and case presentations. Thank you very much. Good night.
Thank you.
Thank you, sir.
Thank you, everyone. Navneet, Karan,
Yes, Doctor.
we can wrap up.
Yes, thank you. Okay, Doctor.
Thank you.